I think we'll have Dr. Daraius Shroff, who will be talking on OCT, how OCT helps in surgical planning in PDR. Dr. Daraius is a vitreoretina consultant at Shroff Eye Centers and the medical director of Shroff Eye Hospitals.
Good morning, everyone. So like Dr. Gagan says, we're going to move in a sequential manner. So first we'll start with how to plan the surgery. So I'll be speaking on how OCT, especially newer advances OCT, can help us plan the surgery in complex cases of PDR. So PDR is actually a proliferative vascular vitreoretinopathy. What does distinguish PDR from PVR? There are three factors which distinguish, and if we keep in mind these three factors, we can always plan our surgery better. Number one is vascular nails. These are the vascular connections between the retina and the fibrovascular tissue. And these always should be dissected carefully. Second point is hemorrhage. PVR, you will not have heme, so you need to have ways to tackle this hemorrhage. And this can also be a clue sometimes to find the plane. And the most important, number three, is vitreoschisis. So vitreoschisis, you can see in this animation, sometimes the heme comes and we have the anterior and the posterior leaf of the cortical vitreous, which is the schisis cavity. And you have to be aware of this. So this is not a new concept. It's been studied from Dr. Paulo Stanga's group from the UK also, where they found swept source OCT to be very, very useful to distinguish the vitreoretinal interface, especially vitreoschisis. And here you can see the two leaflets of the vitreoschisis. So this is one of our own cases. What we wanted to say is that if you go and dissect just under the green arrows, you're going to get the wrong plane. You're going to leave all this tissue there. So you have to make sure you are in the plane of the yellow arrows. And when you have a OCT, you are aware that such a plane exists. So this is the importance. So knowledge of this and identifying it pre and intraop critical, finding the correct plane, being correct plane is essential for success of the dissection. And it's very interesting that if you're in the correct plane, a difficult case can be simple, but it's right the reverse. Incorrect plane makes a simple case messy, and you get lots of complications. So how does the OCT help? It makes best possible to enter the correct subhyaloid plane. You can identify if the attachments are very tight, then you can have a bimanual surgery to start with. You can have precise detection and cutting of the vascular connections and atraumatic removal of the fibrovascular traction. So I think let's move on to some videos. So here we can see this is the surgical video and this is the corresponding OCT. And you can see in this area, you have quite a lot of cleavage plane and you are dissecting here. Now in this area where the arrows are, you can see this is tenting up. This is where the attachments are. So you have to go between the attachments. Now we come to this area, which is the superior part. And here you can see just by putting your assistant to depress, this helps us go in between and get the correct plane. So we are quite fond of doing this. We have an assistant, or if you don't have a good assistant, you can put a chandelier and do it yourself. But this helps you get into correct cleavage plane. What about cases with multi-layered vitreoschisis? So this is also a video. You can enjoy the video. You can see when you have something like this, you have to be very careful and you have to go kind of layer by layer till you get into a correct plane. And now we found a gap. So you can see the gap was inferonasal to a disc. So pre-op imaging kind of guided us that this is where we could have entered. Go on, and areas where there are focal attachments, we can kind of avoid those, tackle them later. So this has all been done with the wide angle system, and sometimes we even use contact lenses. So I'll just show you an example of that. This is the area where it's very, very adherent. So again, the gap, finding the gap on the OCT helps us and kind of helps us to delineate where to enter in these cases. And when you enter the correct plane, you can dissect it. And once you've dissected it, it becomes a smaller piece and it's easier to kind of attack. And here you can see on the OCT, it's multi-layered. And now we have put a contact lens, which we do sometimes, not very regularly, and that helps a more precise dissection. So I think this is probably the last case. So here you can see there's a beautiful separation of the vitreoschisis just temporally. And anterior layer of the vitreoschisis is quite elevated. So it's easy to kind of enter and separate it. This area, I think this is nasal, is not well separated. So sometimes a little bit of help with somebody indentating helps. And when you have these vascular nails, which I was talking about, so this is the vascular nails, this is where we find it very useful to go right hand, we take the scissor, left hand forceps, and when you cut the nails, the retina just falls back. So this helps with a very atraumatic dissection. So to summarize, OCT is a completely non-invasive tool. You don't worry about patients with nephropathy, etc. You can use it multiple times to assess the right plane. It helps us to be better prepared. You need to spend a little hard work. I think a lot of credit Dr. Cyrus, because he spends a lot of time before every case to see the OCT. Sometimes the young surgeons, we just say whatever is on the table we're going to tackle, but I think it's a good way to do it. And it's more accurate than a clinical exam for the peripheral separation, the starting point of dissection, areas of simple and tough dissection. And one thing which we found is sometimes what we call as TRD is very often a retinoschisis. So I think it's a very important point. Of course, the limitations is that if you have a dense vitreous hemorrhage of very, very peripheral pathology, it will fail. So we have to keep in mind that we have to rely on B scans in these cases, which are not so precise. And in the future, 3D scans may give more information. Thank you.
Thank you, Dr. Daraius. So, as you had mentioned that we are more into going in, but do you really feel that if we are I think we don't have much experience with intra-op OCT, but then do you really think that if we really sit down with these scans and study the case before, I think it will be more atraumatic and it will be a better surgical outcome than, was vis-a-vis having an intra-op OCT that time? Or do you think that it can really kind of change the way we look at things now?
I think it's always good to have information. It's like if you're going for a war, you have some intelligence before the war, you can always be more successful. Secondly, two things is that if you know that there's no plane or area, then you can start off with a bimanual surgery. Otherwise, what happens is you start it and then it gets very messy, then you switch to bimanual. So I think it's always better if you are prepared, you know it's going to be tough, you know that the plane is not going to be there. Then from the beginning, you can get your best weapons out, rather than have to, in a midway of a case, when you're in a messy situation, you are bleeding, then you switch to bimanual. So I think this is one way it can help us.
Yeah. Dr. Ritesh. Yeah.
Since you mentioned intraoperative OCT, what we try to study that in preoperative and intraoperative OCTs where we had good visualization. Most of our pre-op OCTs were able to pick up the findings that we wanted to know. One very useful point was to picking up sometimes a hole under a TRD in a cases of CRD was also being able to pick up.
Yeah.
Intraoperative OCT starts to help us once you, in cases where there are vitreous hemorrhages, where you can't really do a preoperative OCT. You do a vitrectomy on table, you do an intraoperative OCT, especially if you have done macular dissection, you're not sure whether you have a full thickness hole or a lamellar hole underneath it. You want to tackle the ILM or you don't want to tackle the ILM. That's the most useful thing that I have found out in intraoperative.
Thank you.
We don't use it so much in our diabetics. I use it in all the PVR cases, but in PDR somehow we don't use it so often. I mean, it is a personal choice. I think many people have shown that it's very useful. So, but sir, have you used intraop OCT or?
I don't have any experience of.
Ma'am, Dr. Dhanushi?
No.
One more sign I would like to highlight about the vitreous cases is like once you have dissected all the membranes and you feel your vitrectomy is done, but there are small streak-like hemorrhages in the peripheral retina, it means that your vitreous is still present over there.
Yeah.
Okay.
It's still not gone, so you have to explore that. In that case, you can put some triamcinolone to identify that residual vitreous. You can do that.
They are popularly known as the red herring, right?
The red flag sign.
The red flag sign, yeah. Yes.
It can happen. I've seen in even like a younger age group, it's more common.
And the sheen also is there, sir? The shine also?
The shine is also there. Once you start exploring it, you'll see that it is getting taut, and it is very adherent. It does not come off so easily. It may even cause breaks while you are.
But do you think sometimes is it better to leave it alone?
It depends. It depends. But I have seen. We actually did a study around, but it was a very small sample size, so I can't conclude on the basis of that. But we have seen that post-operative vitreous cavity hemorrhages and post-operative ERM formations more if we leave that
Right.